We're going to be talking about emergency department care after you've intubated the patient. I do want to start with kind of reminding you how to really intubate like a pro. So, of course, you always want to pre-oxygenate. It's really also important to get it on the first try so everyone knows that you're an expert, but then you kind of want to shrug your shoulders, not a big deal, I do this every day, and immediately admit this patient to the ICU, right? So you've done the hard part, you stabilize this patient, get those high fives, and get that patient upstairs, right? But unfortunately, that's not the end of the game in the emergency department after we intubate our patients. So what I want to talk about today are some of the things that we can do to care for our patients both in the immediate well-being aspect of their time in the emergency department and things we can do looking at their longer-term outcomes. If you Google intubated patient, this intubated Abercrombie and Fitch model comes up. That's not been my experience in how patients look and act when they're intubated, certainly not at Temple. It seems a little bit more like this. And for your longer-term outcomes, we have literature that shows that patients don't do well when they're intubated in the emergency department. On the low end of studies, we're looking at 24% in-hospital mortality. So today what I'll focus on is I want to talk a little bit about sedation and paralysis. And then looking at longer-term outcomes, I want to talk about vent settings that you should be doing in the emergency departments, weaning oxygen early, and trying to avoid ventilator-associated pneumonia. So for sedation, there are studies that are telling us that we're not doing a very good job of intubating patients. This is a relatively recent study in the American Journal of Emergency Medicine, and of the patients that they looked at who were intubated in the emergency department, a third of them didn't get anxiolysis, half of them didn't get anything for pain, and an unfortunate 20% received neither analgesia or anxiolysis while they were intubated. And that's really not acceptable in our field. A great way to figure out whether or not your patient is appropriately sedated and a great way to communicate to other care providers whether or not your patient is appropriately sedated is to use this Richmond Agitation Sedation Scale. Of course, we don't want patients at the high positive numbers. These are patients that are unsafe to themselves and to your staff. And we really don't want them in the deep sedation and unarousable section. Our goal is this 0 to -2 range where patients are appropriately sedated, they're safe, they're comfortable. And although it is tempting to get them down to that -5 so that the nurse doesn't come and talk to you about them anymore, we know that over-sedating patient leads to longer time on the ventilator, longer time in the ICU and in the hospital in general, and then we end up doing unnecessary testing on them because we can't figure out why they're still in a coma. It's because we over-sedated them. Briefly, let's talk about paralysis. I do need to remind you not to paralyze your patients without sedating them, and I know that all of you are saying, I never, ever do that. But that same article that I referenced a couple slides ago tells us that, in fact, we are doing that sometimes. 70 patients who were paralyzed in this study, 67 of those patients did not get appropriate sedation along with that paralysis. So it's something that we're not good at. It's something we need to be more thoughtful about. All right, so moving forward into the more long-term wellness of our patient, let's talk about vent settings. We know that we want to optimize our patients' oxygenation, but on the other hand, we want to limit the trauma that we're giving these patients by intubating them. Most people are familiar with the ARDSNet trial showing that instead of the 10 to 15, we should be using closer to 6 mLs per kg as tidal volumes. And this was on patients with acute respiratory distress syndrome. A few years later, another study came out saying it's not just for ARDS patients. This type of lung protective vent setting is valuable for all patients who are intubated. And what are these vent settings? Well, as we discussed, the 6 mLs per kg of predicted body weight, we know the patients I'm talking about, and then increased PEEP, trying to keep decreased plateau pressures, and weaning oxygen early. I think this is something that we're not always great about because after we've intubated the patients, we have a little bit of that, I did it and I'm going to keep you well oxygenated forever. But oxygen can be dangerous, as tempting as it is to keep them on 100% FiO2. These high levels of FiO2 are associated with poor outcomes. They lead to free radicals, which cause alveolar injury and pulmonary edema. And they'll worsen already lung-injured patients. This may seem like it's something new and cool that we're doing, but it's really not. We have evidence showing, even from back in 2010, that patients who arrived to the ICU and had immediate ABGs that showed what was happening in the emergency department. Patients with hyperoxia had poorer outcomes than patients with a normal PA2, and even patients who were hypoxic. And you know, if Rosen says it's cool, I'm on board too. If you go back to your textbook, you're going to find that he says that you should be weaning your FiO2 to provide the lowest oxygenation saturation to keep you over 90%. Finally, ventilator-associated pneumonia. We also know the consequences of ventilator-associated pneumonia can be serious. Increased mortality in the hospital. They have a longer hospital length of stay by days, and increased cost of their hospital stay, $40,000 more than a patient who doesn't get ventilator-associated pneumonia. Length of stay in the emergency department is directly associated with this. This is a trauma study, but it shows that for every hour the patient spends in the ED after being intubated, their risk of ventilator-associated pneumonia goes up by 20%. And we have similar studies in the Temple ED that have helped us improve our quality of care. This is a great article that goes over evidence-based recommendations to prevent ventilator-associated pneumonia in the ED. And although it's hard for us to look ahead that far, we do know that elevating the head of the bed 30 to 45%, orotracheal suctioning, oral care, and increased cuff pressure, as well as placing an NG tube to avoid aspiration and decompressing the gastric bubbles so that they get improved ventilation, can improve the patient's risk of ventilator-associated pneumonia. So to wrap up, I do want us to think about our immediate well-being of the patient in the emergency department. So we're going to provide good sedation, appropriate paralysis with the sedation. And then looking ahead to their longer-term outcomes, even once they leave our care, we can do things in the ED, like put them on lung protective vent settings, wean their oxygen early and aggressively, and prevent ventilator-associated pneumonia with the steps that I mentioned. Any questions?